all. This is Dr. Mobeen Sayed from drbeen.com. Hopefully you're doing good. Welcome to one more show. And today we're going to talk about a very important study. It's a small study, but it is really important. And that study is revealing that what is going on with children, why do they have lesser symptoms, and how are they able to combat the SARS-CoV-2 infection much better than adults. So that is a fascinating study. Some of the observations in that study contradict the discussions that we have done in the past, for example, cross-reactivity for the children. So I want to talk about that and update us all about that study. Secondly, I want to also talk about AstraZeneca and talk about the severe events that they had. Instead of one, they had two patients, although they did not really reveal more clearly that there were two patients. So I wanted to just very quickly show that as well. So that is the discussion for today. So starting off, first of all, I wanted to thank Margaret McInnes. She is a cool bean who has, for last 3 months, very generously donated and supported our work. So thank you very much, Margaret. Thank you for your help. Having said that, I also wanted to give you an update on the cool bean who was having COVID-19 symptoms. Her RT-PCR came back negative, but her symptoms were she had GIT disturbance, she had headache, she had the sore throat and fever, and her oxygen saturation had started dropping as well. What I had requested her was to start with the prone positioning. She was already for 2 months taking vitamin D, 50,000 international units every week. With that, she was taking vitamin C, vitamin E and A, and a baby aspirin. And then I believe that on my request, she had also gone to her pharmacy to get thiamine and some other supplements as well. So happy to report that she has actually recovered. For a couple of days, she had backache, but now that is recovering as well. The fever and the cough and the headache and the oxygen saturation issues are gone. So we are quite, of course, thankful for this outcome, and congratulations to her. And I had asked this in the past as well, that you or your friends or loved ones, family, if anyone had the COVID-19 or you suspected that they had the COVID-19 while you were working or listening to the topics here, and were you doing anything, were you using any supplements, what was the outcome? It will be interesting to know. In the same vein, I had a tweet from Rob from Florida, and I can probably say it because he tweeted this information, and he said that his child, so Florida has the schools open, so children are going back to school. So his child had developed, I believe, fever, low-grade fever and sore throat, or the symptoms like COVID-19, but happily, fortunately, he has recovered. And Rob had said that he had used zinc and quercetin and vitamin D and other supplements. So he was quite happy as well. And we are quite happy about that as well. So some good news. And let us start our discussion for today. The question is, why do children handle COVID-19 better? James, thank you very much. Yes, I am so happy. So now we have about 172 videos, and the primary outcome, the primary purpose of these videos was to help us all explore this information together. And as the pandemic is evolving, we all kind of try to figure it out together and be protected and safe. So I'm very pleased that the results so far in Cool Beans and the patients that I have directly managed, the results are great. Again, all the patients that I managed, none of them, thank God, have ended up in hospital or God forbid, even worse. So that is the situation. Let's start. So here is the study itself. The study is This is the study, immune response to SARS-CoV-2 infection in hospitalized pediatric and adult patients. So they said that the normal cut-off range, age range, is 21 and below are children and youth. However, in this study, they used 24 and below as the children and youth. And I think the eldest child or youth in their study was 22 years old. This is a study, and I'm going to discuss this over here. The important thing is it's a small study. I think it's 68 patients total. Second important thing is that whatever conclusions they have made those conclusions as maybe conclusions. These are not deterministic conclusions. However, they have evidence to support what they're saying. So with this, let's look at it. What they did was the following. The basic gist is this, that in children, the immune system is stronger compared to adults. So this is we adults, and our immune system is kind of a little lazy panda over here, not doing very good kung fu. And this thing for the children is a better immune system. Now, please remember this. It's not that the children's immune system is robust all around. What they found was that one arm of the children's immune system, innate arm, is more aggressive and robust compared to adults. That is one. And the second finding they found was, in case of children, when the infection occurs, it is the innate arm that immediately takes care of the infection and clears the virus. So the adaptive arm that is responsible to produce antibodies, or that is responsible to activate cytotoxic T cells, that adaptive arm is very little activated. And in the adults, it's the other way around. In the adults, the innate arm is less active, less functional, causes less work. Instead, it activates the adaptive arm and asks the adaptive arm to do the function. So it kind of hands off the duties to the adaptive arm compared to children, where innate arm does better. Now, they've tried to answer this question, that why is it that the children's innate arm is better than adults' innate arm? And so they had multiple theories and possibilities. We'll talk about those. But this is the basic gist of the discussion, which means the takeaway for us is, when we are trying to protect ourselves from the virus, it should be important for us to make our innate arm better and stronger compared to the adaptive arm. And this reminds me that about 3 or 4 months ago, it seems like years nowadays, 3 or 4 months ago, I had talked about natural killer cells and a need to enhance and make our natural killer cells better in adults. And this is exactly the kind of study that is proving that point. So we had talked about it about 4 months ago. And I remember that there was a company who had natural killer cells related products, and they had gone on Fox and other news media, and they had made a lot of noise. And we did a video about natural killer cells as well, where they had said that it is important that natural killer cells in adults are robust and available. I don't think that they got much traction, but this study kind of proves that that is a primary difference between the children and the adults. So let's see. Here is what that study found. Study found that the adults that were 24 years and above, or greater than 24 years of age, they actually, so listen to this, this is such an interesting thing. They actually had higher titers, meaning quantities of neutralizing antibodies. That means adults had more activation of the adaptive arm and more production of the neutralizing antibodies compared to children. So it is not that the adult's immune system was responding in a weak way. In fact, it was responding more aggressive compared to children, but aggressive through adaptive arm. Children's immune system responded more aggressively on the innate arm side. So the proof that the study found was that in adults, the neutralizing antibodies were actually more than found in the children. Then phagocytosis, and we'll discuss that in the next slide. But what happens is, we have done this discussion before as well, when the antibodies are produced, then those antibodies bind with the antigen, for example, SARS-CoV-2 in this case, then that antigen connects, the antibody and antigen complex connects with the macrophages, and macrophages would phagocytose that whole thing. And I have done a complete lecture about that as well, a talk about that. So that is the antibody dependent cellular phagocytosis. And in adults, that kind of phagocytosis or clearing of the virus was actually even more aggressive, which means what? I'll discuss that in the next visual, so it is easier to see in visually. And then finally, the T cell function in adults was actually more aggressive compared to children. And again, that is adaptive arm. T cells are adaptive arm. So all of these prove that adults' adaptive arm was more robustly working compared to children. On the other hand, children's arm, number one, they found that there was no role of cross reactivity. What that means is that if a child becomes sick from another infection, then it is not necessary that the immune system's preparation for that infection was giving children protection from SARS-CoV-2. So they did not find any evidence of that in their cellular profiles. Secondly, what they observed was that in children, when they get sick with COVID-19, they immediately start producing interleukin-17 and interferon-gamma. This did not happen in adults, or this also did not happen in those children that became severely ill and needed ventilation, or that became severely ill with multiple organ inflammatory syndrome. So that is very interesting that even within the children, those children whose innate system did not kick in right in the beginning aggressively, they behaved in the progress of the disease similar to adults. And so now this is what I'm going to explain, that how did that happen. And so let's see here. I think we are all very much familiar with this diagram, and I'm going to start from here. So imagine when the virus or pathogen enters our body, our innate system starts functioning, and there are many, many cells of the innate system. Here, I just made one representative cell, and that is dendritic cell. There are macrophages here, dendritic cells here, then there are natural killer cells here. There are other T lymphocytes here on the innate side that are going to work to try to, neutrophils are here to try to clear the infection. So here, the regular normal process is that dendritic cell eats up the pathogen, then it releases some cytokines, then it presents the antigen to the naive T cell. Naive T cell, in the presence of interleukin-4, becomes T helper 2 cell. T helper 2 cell then releases interleukin-4, 5, interleukin-10, and many other cytokines that causes the B cell proliferation and differentiation, and B cells become plasma cells. Plasma cells are nothing but active B cells. Now these plasma cells are producing antibodies, which are the immunoglobulins that we have been looking for so long. And then I'm going to go one step further from here. In our previous talks, we usually stop here and say, this is one endpoint of the activation. Here now, please check this out, that these antibodies can do a lots of functions. One, they neutralize the pathogen. They bind to the spike protein of the pathogen, and as they cover it and bind it, the pathogen finds it difficult to connect with the ACE2 enzyme and get into a cell. So that is neutralizing behavior. Similarly, when the neutralizing antibodies will connect with the pathogen here, so look at this diagram, this antibody will then connect with the macrophages or other cells that can do phagocytosis. This is antibody-dependent phagocytosis. There is a direct phagocytosis where the macrophages or dendritic cells have Toll-like receptors or PAMPs or other receptors that can directly bind with the antigen or virus and eat it up, help the cell eat it up. Here, instead of directly connecting with the antigen, with the pathogen, the macrophage is connecting with the antibody. So we say that we have FC receptors here. And that antibody and pathogen complex is then internalized in the cell, and that is phagocytosis. In result of that phagocytosis, not only the pathogen is cleared out, but there are more cytokines that are released, and that would amplify the immune system. Good. So keep this much in your mind, especially this part here, because we're going to come back and address that. And we also know that it is possible that when an antigen is presented to the naive T cell, if interleukin 12 is released or is present, that interleukin 12 would cause the naive T cell to switch to become T helper 1 cell. T helper 1 cell would then in turn release interleukin 2, which will cause the activation of cytotoxic T cell or CD8 plus T cells. And these cytotoxic T cells, I think we have talked about it many times, they would then release granzymes and perforins, and that would cause the cells that are infected with the pathogen to be destroyed. So that is the cytotoxic clearing of the cell. Then we also had done this discussion, that's why I'm going fast on this one. We had done this discussion as well, that in the presence of interleukin 23, the naive T cell can become T helper 17 cell, which is a regulatory T cell. And this T regulatory cell, or Treg, will in turn release interleukin 17A. And that interleukin is important for today because that is a primary interleukin they found in children, present more in the early stage compared to adults. So keep an eye on the interleukin 17, that this discussion is about interleukin 17. So this T helper 17 will release interleukin 17, and it A and F and other, we call them interleukin 17 family. And it would also release GM-CSF, which is granulocyte monocyte colony stimulating factor. This GM-CSF would go and act on a bone marrow, and then bone marrow would produce more neutrophils, and the neutrophils are part of the innate arm, and now the innate arm has become activated and robust or amplified. Good. So now we know 3. There are more branches here as well, but these 3 are important. Now check this out. What happens in adults? What happens in adults, majority, is this pathway, T helper 2 pathway, which goes towards production of antibodies, which then activates the macrophages and the antibody-dependent cellular phagocytotic activity. That is what happens in adults. So what happens eventually is that, let's say if I get the infection today, it is possible that 80% of my response is coming from antibody production, 20% is coming from cytotoxic T cell behavior here. In some other people, it may be that cytotoxic T cell behavior is 80% and the plasma cell behavior is 20% contributing towards clearing of the virus. So there can be differences in their percentage of activation. But please remember this, that this is the adaptive arm and this is the innate arm. In the children, the innate arm becomes more robust. In the adults, the adaptive arm becomes more robust, and that is a primary difference. So of course, the conclusion they are making is that, hey, try to make sure that in adults, the innate arm becomes more robust and more strong compared to the adaptive arm. So now let's see what happens in children. In children, what they're saying is that they see a lot of memory cells in the lung epithelium. So this study is primarily towards the respiratory infections. And they're saying in children, there are memory cells present, already present in the epithelium or in the tissue of the lungs. These cells are called CD161 positive. This cluster of designation 161 simply means these are memory cells. What kind of memory cells are present? There are cytotoxic T cells, memory cell present. So we saw cytotoxic cells here as well. We're not talking about them. The virus, imagine if I'm a child, which some claim that I am. So if I'm a child, let's say my age is 12 years. And the virus enters my respiratory system. Virus does not have to cause this whole pathway to become activated. Children already have these cytotoxic CD161 positive memory cells which produce interleukin 17 and interferon gamma. So as soon as the virus enters a child's epithelial system or the respiratory system immediately starts releasing interleukin 17 and interferon gamma. So this is one cell that is present there doing this function. The other cell that is also present there as a memory cell is the T helper 17 cell. And in the study, they say, we do not know why they are sitting there. We do not know what is the significance of them already being there. But they know from the cell profiles that these cells are present. So this T helper 17 here, which is T regulatory cell, is also producing interleukin 17A and interferon gamma. So in the study, they are saying that the interleukin 17A and interferon gamma that they are observing is not coming from here, or I did not make interferon gamma here. Interferon gamma is produced by these cells. Interferon gamma produced by this cell as well, and many other cells can produce interferon gamma. But if you see that this interferon gamma production will only occur when the adaptive arm has become activated. But they're saying adaptive arm is yet not active, and interferons gamma and interleukin 17A are already present in children. And so there are memory cells that are producing them. And we do not need the adaptive arm to become active. Second thing, they also observed that the respiratory epithelium of children, the surface cells of the respiratory system of children, epithelium of children, is also able to produce interferon gamma as soon as the virus or pathogen enters them. This does not happen in adults, or I should say it does not happen strongly in adults. And they have a few theories that why does that not happen. They feel that the adult cells, the memory cells and the natural killer cells, they are not as robust in their activation, and their cellular receptors are not as strong and as efficient. So you can say that it is kind of a worn out innate immune system that we adults have. And children's immune system, innate system, is still very, very robust and strong. And then finally, interleukin 7A is also produced by natural killer cells, which are also part of the innate arm. So now imagine, compare two people, adult and a child. Child gets the virus, immediately the memory cells and epithelial cells and natural killer cells, they start producing interleukin 17A and interferon gamma. That in turn immediately causes the immune system to respond fast enough and rapidly enough to become active to clear the virus. So did you see here that the interleukin 17 would cause the neutrophil to become activated, and the neutrophil is part of the innate arm and it is going to start clearing the virus. Similarly, if we have interferon gamma present, interferon gamma activates the macrophages and the dendritic cells, and their function is also to eat up the pathogen and start clearing it. So what happened here? Innate arm itself became amplified. Instead of saying to the adaptive arm that, hey, adaptive arm, I need you to work, innate arm released cytokines that amplified its own self, and the function of innate arm increased. That increased function of the innate arm is sufficient to clear the virus successfully without much symptoms right in the beginning. And in the study, they found that those children who ended up, let's say, in ICUs or on ventilators, their innate arm could not mount a response like this. So that means their system behaved very similar to adults. Fortunate for all of us who have children that this happens in a very rare case. Now, on the other hand, in case of adults, what happens is these pathways become active, the adaptive arm become active, and when that becomes active, then this happens, antibody dependent cellular phagocytosis. And they are saying in the study that this seems to be an anomaly. And this happens And this happens more than children. So this seems to be an anomaly as well. And this happens, cytotoxic T cells work more than children, and that also seems to be an anomaly. So in general, I would say that the adaptive arms behavior and activation becomes a problem. So let's just very quickly look at the study. I'm not going to read it, all of it, but just wanted to point you, and I have the link in the description. So if you go there and look at the discussion, a few things here, results of our study. So they have gone over what I just discussed. This is an important paragraph here. Dual cytokine, interleukin-17A and interferon-gamma producing resident memory cells have been described in the lung, and a protective role of T helper 17 cells has been described in pulmonary infection. In addition, pulmonary epithelial cells, surface cells, have been shown to be source of interferon gamma during infection with Mycobacterium tuberculosis. Possibly the higher concentration of interferon gamma and IL-17A in the serum of pediatric patients, children, with COVID-19 reflected increased expression by cells in the respiratory tract, and these local cytokines may have protected the patient from progressive respiratory disease. Then they continue on and discuss that why does this not happen in adults? And then finally, they make a conclusion here. The finding that adults who did poorly had high titers of antibodies, they had more antibodies, and they're doing poorly, which were both neutralizing and induced phagocytosis, as well as the greater T cell response, suggests that boosting of these functional responses to spike protein, particularly late in the course of disease, may not be beneficial. A patient, adult patient suffering from COVID-19, already having lots of antibodies and T cells, they are saying possibly do not augment these functions further, because that is what causes the damage. In contrast, boosting of early innate immune response may be important. So I was thinking that one of the takeaway for us is that we should think about what are the ways to boost innate arm. So maybe if you are okay, tomorrow we can talk about how do we boost the innate arm. So that is one part of the discussion today. Second part, so let me just show you the conclusion here. Conclusion is children have diminished adaptive immune response, diminished adaptive, robust, innate. Adults have diminished innate, robust, adaptive. Secondly, the proof that they gave was that in children, interleukin 6 is less. That is produced by macrophages that are activating the adaptive system. Tumor necrosis factor is less. That is, again, macrophage activation syndrome. Then phagocytosis is less. That means that antibody production is less, and then antibody-dependent phagocytosis is less. That means adaptive arm is less active in children. So this was their conclusion. Very, very interesting and exciting study. It gives us one more way of fighting the disease. And now, finally, AstraZeneca. So I have been calling it AstraZeneca. Somebody pointed out that it is Zeneca. So with due apology, AstraZeneca. This is their patient enrollment document. And this is 11th September 2020. And I thought there was something that maybe disingenuous on their end, or maybe this is just how it is. And that was, they talked about the, if you see here, serious reactions. And in the serious reactions, they didn't talk, so they actually had 2 patients of transverse myelitis instead of 1. But they did not make it a bigger news, or they did not help people know it that clearly. So in their document here, if you read this, reactions in the nervous system are also extremely rare, but can include an illness called Gearberry Syndrome, a condition in which people can develop severe weakness and can be fatal. But hear this out. Now they're going to talk about 2 patients, but they are not going to talk about 2 patients. And the news cycle kept going with 1 patient, and they just kind of piggybacked on that. So let's look at their phraseology here. These adverse events have not been previously seen following administration of similar vaccines using ChAdOx1 as a viral vector. In the current trial, We have undertaken safety review when volunteers in the trial, so see, not volunteer, volunteers in the trial of ChAdOx1-CoV-19 developed unexplained neurological symptoms, including changed sensation or limb weakness, and have paused the study while a safety review took place. So when they paused the study, this was volunteers. Why did they have to kind of say it this way? Anyways, after independent review, these illnesses were either considered unlikely to be associated with the vaccine, or there was insufficient evidence to say for certain that the illness were or were not related to the vaccine. So they're saying, don't know. In each of these cases, so see, in each of these cases, it's not that in this case of transverse myelitis that we all know. So there were actually 2 women, I think, in UK who got transverse myelitis. So in each of these cases, after considering the information, the independent reviewers recommended that vaccination should continue, close monitoring of the affected individuals and other participants will be continued. So sorry that Luffy was very active today. This is the discussion for today. I hope that you liked it. Tomorrow, if you allow me, I was actually going to talk about neurological defects or issues that occur because of COVID-19. But after doing this study, I thought it may be more interesting to look at how do we improve our innate arm by external help or by foods or supplements or other such lifestyle changes. So if you are comfortable, we can talk about that. Otherwise, I wanted to talk about the neurological symptoms as well. And yes, I forgot, somebody put a comment here, green tea supplement has massively helped me to, on top of other polyphenols, which are mast cell stabilizers. And from this, I remembered that the cool bean who had become ill, she was taking green tea, I believe, 2 times a day as well. So this is it for today. Thank you very much. And I would see you tomorrow. My request to you, please like, subscribe, and share. And if you feel that you would like to donate to our work, the link for donation is in the description as well. So thank you very much. Love you all. See you tomorrow.